The case is of a 54-year-old male. I mentioned he had left-sided visual field loss, left-sided weakness and confusion. His exam was a fluctuating mental status, left homonymous hemianopsia, right gaze preference, and then left-sided facial droop, mild or possible hemiparesis, sensation deficit, and hemi-neglect. He presented as a stroke code. He was admitted. He was treated empirically for meningoencephalitis. He had a brain MRI that we'll review in a minute. He had an LP done that was bland, but did show mildly elevated protein. He had his course was completed by recurrent seizures. He had convulsive and non-convulsive seizures, including status, and EEG was done but did not capture these seizures. It did show diffuse slowing and right focal slowing. On day 10, he had persistent deficits with negative autoimmune, infectious, and malignancy workup. So here is his imaging from the outside hospital. Move this. Oh, I'm sorry. I was trying to get rid of that bar.
I'll show you. Go to more. Hide floating medium control.
Thank you. Okay, so here is his MRI. You can see, first of all, the DWI was negative for any acute stroke. The flare shows T2 hyperintensity, cortical T2 hyperintensity in the right parietal region, gyral thickening, and sulcal effacement. There is sparing of the white matter. The enhancement is a little bit more difficult to appreciate, but especially if you compare to the left side, that you'll see right leptomeningeal enhancement in the same region. So the presumptive diagnosis was post-radiation effects. These can be classified by time from radiation therapy. So days to weeks is considered acute effects, 1 to 6 months is early delayed, and greater than 6 months is late delayed. These are typically irreversible, but as we'll see in this case, there are some situations where they are reversible. We'll be focusing on the greater than 6 months since the patient had radiation therapy about 5 years prior. So I do want to draw your attention to the images here on the side. The top is what it looks like for a patient to undergo external beam cranial radiation therapy, and the bottom is a prototypical planning of radiation treatment, specifically for scalp treatment. And so the lines here, you can see the treatment zone is the pink. Right outside the treatment zone is the orange, where about 95% of the dose is delivered. And then subsequently in the yellow zone, 70% of the dose, green 50, and blue 30. So this patient's presentation was most consistent with stroke-like migraine attack after radiation therapy. This is, or SMART syndrome for short. This is a very rare and late delayed effect of radiation therapy. The clinical features, several are in the name, and I have some images here. The migraine, you can see, as well as focal neurologic deficits or stroke-like symptoms. Notably, what's not in the name are seizures, which are also very common, can become very difficult to control, as well as confusion. So this develops acutely over hours to days. And then the symptoms tend to be prolonged on the order of weeks. The mean onset is 14 years post-radiation therapy. Is associated with a greater than 50 gray dose. And this patient notably had about 73 gray. There are characteristic MRI findings, which we already went through. I think it's important to note this is so rare that you should make sure you cannot attribute the symptoms to another disorder.
It's not rare at grand mountains.
Yeah, that's true. It does notably have a good prognosis, with most patients having recovery in about anywhere from like 6 to 12 weeks. Though there is a risk for recurrence in about half of patients. There is risk for persistent deficits in about a fifth, and then a risk for subsequent stroke in about 15%. So the pathogenesis is not fully elucidated. It is thought to be multifactorial with several mechanisms that have been proposed. So radiation damage, radiation can cause mitochondrial damage and reactive oxidative species. This can then lead to neuronal dysfunction and blood-brain barrier endothelial dysfunction with disruption of ion homeostasis and hyperexcitability. That then leads to the cortical spreading depression. which increases risk for seizures. This is similar to the pathogenesis for MELAS. Also implicated is the trigeminal system impairment, which can help explain the migraines. And then lastly, radiation brain injury is thought to cause vascular dysregulation, resulting in blood-brain barrier disruption and cerebral edema, which is similar to PRESS. So there are some additional findings that have been seen in case studies beyond the MRI changes. So EEGs have shown nonspecific and diffuse slowing, as well as seizures, CSF with mild protein elevation or otherwise bland. DSA and some case series showed a string of beads pattern, kind of similar to PRESS. Interestingly, the PET scan has showed a regional hypermetabolism in the acute phase and then subsequent hypometabolism, and then biopsy shows nonspecific gliosis. So in this patient's case, he received 5 days of 1 gram solumedrol plus Keppra, which did require escalation due to recurrent seizures. He was discharged home after some improvement over 10 days. At a neurologic exam 3 months later, he had resolution of the deficits. However, he did have a new right P2 stroke. There is no established treatment or guidelines really around treatment. However, different things that have been recommended, starting seizure medications if there's seizures, verapamil for headaches. You can consider high-dose steroids for focal deficits. This is sort of disputed in the very limited literature because on the one hand, the high-dose steroids can help eliminate the MRI changes, which is really important if you're considering the high risk for cancer recurrence and leptomeningeal carcinomatosis in these patients, and you want to ensure that those findings do resolve over time. But in a very limited case, in a very limited study at N of 11, it showed a negative prognostic outcome for prolonged deficits. L-arginine has been used in several case studies with good effect, which is interestingly a treatment for the stroke-like episodes of MELAS. And then a repeat brain MRI is recommended in 2 to 4 weeks, given you want to see the resolution of those findings. And these are my conclusions. Happy to take any questions.
Afterwards. Thank you, Maria.
You're welcome.
Leave your laptop. Just hit stop share. There you go. Okay. Yeah, thank you.
You're welcome.
Thank you, Maria. Abhay, you can hit your start share. I'm just going to talk about you.
Sure.
So there he is. So Ray, that's me in the painting behind him when I had orange hair. So I've known Abhay for a very long time. I think this is his 3rd time doing grand rounds here, just because he's an amazing speaker and a physician. Abhay was a medicine resident at Harbor Hospital in Baltimore. We used to call it Haba Hospital. And he did a rotation through neurology at Hopkins. And the residents were so stunned by him, they demanded that he get a residency slot at Hopkins in neurology, which is what he really wanted to do. And so he came over as a resident and has never left. I'm not exactly sure how Abhay got into disorders of CSF production or overproduction, but he's now probably the world's expert neurologist on both CSF overproduction, as in idiopathic intracranial hypertension, and low pressures, and normal pressure hydrocephalus. And due to that, Abhay's been awash in spinal fluid for 15, 20 years now, and he's used that spinal fluid to really come up with some incredibly interesting insights into various neurodegenerative disorders. So anyway, it's a true privilege, an honor to have Abhay give a talk. And more than that, it's an amazing educational opportunity for anyone who sees him talk. So Abhay, I will let you take it away.
Thanks, Rich. That's too generous of an introduction.
No, it's not.
In the interest of time, I may skip some slides, so bear with me. So I asked my favorite medical reference, about why is there so much controversy about normal pressure hydrocephalus? There seems to be, wide variety of opinions about this. And, it gave a pretty fluid summary of the current state of affairs, but the most important line was the last one, that NPH may be overdiagnosed because a shunt seems like a relatively straightforward and simple solution to a complex set of symptoms. And that's what I'm trying to address in this talk. So the way I got into hydrocephalus was Mike Williams, who was heading this NPH program here at Hopkins, left, and there was no one else interested in seeing these patients. And actually, Rich asked me, can you take over their program? It seems like a good program to get into for various reasons. But while I was doing my residency and I was seeing these patients, these were my questions, and there were even more questions. Why do neurosurgeons believe in it and neurologists don't? And if somebody has all the three classic features and big ventricles, why not just shunt them? Why go through this process of doing an LP or a drainage trial? Subsequently, people said, at least in the neurology movement disorders field, oh, NPH is just a pre-degenerative phase. Well, why are there no double-blind randomized controlled trials for NPH? We have RCTs for deep brain stimulation for Parkinson's disease, there are device trials in PD, but why not shunts for NPH? And some more fundamental questions, how do normal pressures cause big ventricles? And isn't there a placebo response to a large volume LP or ELD? And that's an important question because you're essentially telling a patient that, I'm going to do this LP, drain some CSF, and if you improve, you're going to get a shunt and you're going to do much better. And if you don't improve, you're not going to get a shunt and you likely have some degenerative disorder. So there's a huge placebo response that you have to account for when you do these procedures. So we'll get to most of these questions, if not all of them, in the talk today. So NPH was first described by a neurosurgeon from Columbia and along with neurologists and neurosurgeons at MGH at Harvard. And in the 1960s, and back then before the era of CT scans, they did pneumoencephalography. And as you can see, air inside the ventricles could be imaged by X-rays, and they noticed that these ventricles were large. They drained CSF from them, and they improved. Though they did caution them, that the interpretation of moderately large ventricles due to hydrocephalus versus atrophy may lead to some diagnostic uncertainty. So that's when they describe the triad, we all know. And, once that article came out, everybody started shunting patients with big ventricles and elements of the triad. Because as you can imagine, it was sold as a cure for senile dementia, and who wouldn't want to do that, right? So J.P. Moore, one of the neurologists at the time, said, everybody started doing it, right? And interestingly, Houston Merritt, who was born a few miles from where you are in Wilmington, North Carolina, he was a resident in neurology at Hopkins, went on to be the chair of neurology at Columbia and dean of Columbia, also wrote a good book about neurology. He, in fact, at that time said, that Adams and Hakim should lose their professorships for publishing such premature observations, because back then shunt-related complications were very common. Death or severe morbidity happened in 7% of the time. A good example is the subdural, as you can see on the right over here. And on the left is an image of a patient with ventriculitis that happened in a patient with a shunt. It literally chews out your brain from the inside. And interestingly, Houston Merritt himself developed the triad and big ventricles. And he said, nobody's going to shunt me over my dead body. But somehow, his colleagues convinced him to go to Boston and get evaluated. He got a shunt, and a month later, he was dead from complications related to the shunt surgery. And that's when really neurologists, took a step back and stopped believing that shunts help people with NPH. And NPH became the domain of neurosurgeons for, I would say, a good 3 to 4 decades, though lately neurologists seem to be getting back interested as more evidence is accumulated about benefit from shunt surgeries. So then coming back to some of the questions I asked earlier, why shouldn't we shunt everyone who has the triad and ventriculomegaly? Do you need the triad? Is it enough to make the diagnosis? And is the full triad necessary to make the diagnosis? So again, you have the triad, big ventricles. Why not just shunt these people? Why are we doing all these extensive testing? So if you look at the prevalence of each of these individual features of the triad in the aging population, dementia affects 5%, but MCI affects around 40% of patients by the time they are 85. Urinary incontinence due to pelvic floor weakness is present in 38% in women, and 20% of men over 60 have BPH. And gait abnormalities due to osteoarthritis, spinal degeneration, peripheral neuropathy is prevalent in 50% of those over 85. So you can imagine in the general population, a large number of people will have this triad, but NPH likely constitutes a very small fraction of these people with the triad. So coming to imaging, so ventriculomegaly, classically in NPH is defined by the Evans ratio, where you take the ratio of the maximal bifrontal ventricular diameter and divide that by the maximum biparietal diameter at that same plane. And historically, Evans ratio has been defined as anything greater than 0.3 is hydrocephalus or ventriculomegaly. And in the sagittal section, you can see normally the corpus callosum is a thick bundle of fibers in the midline. And with NPH, the corpus callosum gets stretched like a balloon-like configuration and becomes thin and stretched. So ADNI, has shown very clearly that, in patients with Alzheimer's disease, obviously ventricles enlarge over time, but ventriculomegaly can start even in the preclinical phase in the MCI stage. And even just with normal aging, your ventricles increase, even at as short an interval as 6 months. So ventriculomegaly is not a core feature of hydrocephalus. Ventriculomegaly is seen in multiple neurodegenerative disorders, including just normal aging. So based on the ADNI study, they then came up with cutoffs for ADNI that are age and sex adjusted. And as you can see, once you factor in age and sex, the cutoffs for ventriculomegaly are much higher than the traditional 0.3 that's been used, in like all publications of NPH, right? So by the time you're 65 to 69, the cutoff is around 0.34 for males, 0.32 for females. And by the time you're in your 80s, that cutoff is much higher, 0.37 and 0.36. So a lot of people out there who have shunts likely don't meet these cutoffs. So to conclude, the triad is widely prevalent in the aging population, independent of hydrocephalus, and ventriculomegaly is common to many neurodegenerative conditions and normal aging. So if you think of all the common dementias, so obviously AD, DLB, PSP, CBD, all of them have ventriculomegaly. Only pure idiopathic Parkinson's disease in the non-dementia phase doesn't have ventriculomegaly, but even those patients, when they develop dementia, develop ventriculomegaly. Then coming to the question of, is the triad necessary for the diagnosis? And in fact, multiple studies have now shown that gait dysfunction may be the only symptom of NPH, and it's often the first symptom of NPH. And if you don't identify it in that phase, then it's followed by cognitive impairment and urinary incontinence. And eventually, everyone will develop the triad, but you don't necessarily need all elements of the triad. And that's another classic feature, is that gait disturbance precedes cognitive impairment in virtually everyone. And if you see the converse, you should think more of a neurodegenerative condition rather than NPH. Is there a classic gait? In medical school and in residency, we all learn about the classic gait of NPH is a magnetic gait, or an apraxia of the gait where the feet are stuck to the floor and widened base. But that's common, but it's not pathognomic. You can see very similar gait abnormalities in many other conditions as listed over here. So there is no classic or pathognomic gait of NPH. So then, can MRI help in identifying patients better? Are there other features on the MRI that can be used to select these patients for shunt surgery beyond just the Evans index? And one of the commonest additional features that we use and many other centers now use is this MRI-Callosal Angle, where you can see in patients who develop ventriculomegaly in NPH, for reasons that we still don't know, the ventriculomegaly, the lateral ventricles expand superiorly. So that's what causes the crowding of the sulci at the top, as you can see over here and here. And that causes the corpus callosum to develop like an acute angle. That acute angle, generally less than 63 is considered a good cutoff. I mean, the initial studies had a very low Youden's index, but subsequent studies have shown that it's actually better. Youden's index has to be done at the level of the posterior commissure. So you have to make sure that's the plane that you're doing it in. That's the posterior commissure you see over there. And the horizontal plane to compare to is the line connecting the posterior commissure to the start of the lamina terminalis over here. And at that plane, if you measure the corpus callosal angle, you can see that it is quite acute in patients who eventually respond to shunt surgery. That's a very simple measure to take. As long as you've got good coronals, you can reformat your axials to coronals if you have good resolution on your axial sequences. Then, people wanted to see, can just combining the callosal angle with the Evans index, is this enough as compared to doing whole brain and ventricular volumetrics? So in this study, they calculated the volume of CSF in all the ventricles, including the extraventricular CSF. And they looked at, can just the Evans index and callosal angle, predict who has NPH versus healthy controls versus AD. And as you can see, that combining the Evans index, so somebody with a high Evans index and a low callosal angle, all these blue dots, the NPH population definitely seems to fall into that category as compared to healthy controls, which are in these green, and the AD patients who are in red. And in others, other analysis, they showed that this model just combining the Evans index and callosal angle was equivalent to doing more sophisticated volumetrics of the ventricles and gray and white matter and hippocampal volumes. So this is a simple test that you can do easily in your clinic patients. Earlier, there was a lot of hype about measuring the actual aqueductal stroke volume. So in the plane of the aqueduct, with cine imaging, you can do you can actually measure the volume of CSF with every cardiac cycle. And they claimed a sensitivity and specificity approaching like 100%, a positive predictive value of 100%. But this was a single site study. And when we tried to replicate this in our site in a much larger cohort with much longer follow-up, we did not find that the stroke volume predicted anything. The Japanese came up with this concept of this disproportionately enlarged subarachnoid space hydrocephalus. They call it DESH. And that's based on this, again, this expansion of the ventricle superiorly. So the ventricles expand superiorly to the convex, the sulci at the top get compressed, but that increases the CSF volume in these subarachnoid spaces. In the Sylvian fissure over here, you can see, it went from around 2 to 3 to around 7 to 9. So they, in fact, use this as their core criteria for both diagnosis and selecting patients for shunt surgery. And they've shown that the DESH score correlates with modified Rankin scale. In many of their randomized studies, they use the DESH score as their primary selection criteria. But again, when we and others in Europe have tried to replicate the DESH score in larger cohorts, we found that, again, it did not predict improvement. It did not correlate with gait. It did not correlate with improvement in either the cognition or gait and tinnitus and tug after. So I think most people in the US and Europe use this, as an ancillary tool, but not necessarily as a criteria for selection. How about applying more advanced machine learning approaches? So we did a pilot study of this at Hopkins, where we selected patients who underwent shunt surgery versus patients who were not selected for shunt surgery. And as you can see, as the number of features increases from like 4 to 79, your precision improves and the sensitivity and specificity go into are very high. So, multiple MRI features can be combined to predict who will improve after shunt surgery. Just showing this in a different way with the AUC of around 0.94. And if you look at what features is the model selecting, obviously ventricular volume is selected. The larger the ventricular volume, the more likely you're responding to shunt surgery. But interestingly, it's looking at features in the brainstem, so the midbrain, the medulla. So likely these are negative selection features, meaning it's identifying people who have midbrain atrophy due to PSP, who have DLB and brainstem atrophy. It's selecting some cortical areas in the parietal association cortex. So essentially people with AD. So it's both selecting for positive features like ventricular volume, but also negative features. It's the thinning of the corpus callosum. So it's identifying features that both positively identify people with NPH, but also negatively selecting against patients who have some neurodegenerative condition, which I found very instructive. And again, this is just the tables that go along with the explanation of that figure. And it also reasonably correlates with improvement in MMSE after shunt surgery. But again, this is a single site study, and we are looking at a larger multi-site validation for this in a separate multi-center clinical study that I'll talk about later. So what is a standard assessment of NPH? What do we actually do when we see patients in the clinic? This is the official recommendation of the NPH guidelines, fairly complicated. People use CSF dynamic testing in Europe where they calculate CSF outflow resistance. Hardly anybody in the US does that. But our assessment is fairly simple. We test their cognition and gait when they come to the clinic with some quantitative measures. They all get imaging. And generally, we refer them for a single large volume lumbar puncture first. If they don't respond to the lumbar puncture, we refer them for the extended CSF drainage trial. Some people who've already had LPs outside before coming to us, then we just send them directly to the CSF drainage trial for draining the 300 to 600 cc's. So the single large volume LP, our goal is to drain anywhere from 40 to 50 ml. It's important to note that it has a high positive predictive value, but an average negative predictive value means if somebody responds to a large volume LP, there's a high likelihood that they will respond to shunt surgery. But the large volume LP may miss nearly 50 to 60% of patients who would have improved after shunt surgery. Typically, gait velocity is the primary outcome. The step frequency, step height, or base doesn't change as much in this one study. We typically do multiple measures of gait, which we'll come to later, but the most widely used test in the world is the timed up and go test. Some people use a 10-meter walk. The tug is very simple to do. It takes less than a couple of minutes to do it in the clinic. It's a very easily done quantifiable measure. You have them seated on a chair, walk 10 feet, turn around, come back and sit down. You do an assessment immediately before the LP and within 2 hours. And you can extend this to later, but generally if you take out 40 to 50 ml, you'll make it all up within 2 hours. CSF production is around 20 to 25 ml an hour, unless you've caused a leak. If you use a large bore needle and you do the LP and you cause a leak, then yes, the benefit may last longer than just 2 hours. The more important question is, what is reliable change? How much does your tug or whatever criteria you use to improve, how much does it need to change by? Remember, there's this huge placebo effect that we worry about. And if you don't improve in the large volume LP, is it just not NPH? Did you use a less sensitive test? Were you delayed in your assessment? So coming to reliable change, I'm going to skip over the statistical section of this part. So essentially, the reliable change factors in the variability of the test measure itself. So it accounts for measurement error when you administer the test repeatedly over time. And it looks at how good the inter-rater reliability is. So essentially for Tenetti or the mini best, Tenetti is a measure of balance. The mini best is another more sophisticated measure of balance. You have to improve in at least 5 points out of 30. So it's a much higher threshold than in practice. In many centers, they use just a 2 or 3 point improvement. Similarly, in the tug and the 6-minute walk, the 6-minute walk is a well-validated scale of endurance. You need to, so in both scales, you need to improve on these times by 30%. And again, at many sites, and if you look at many papers, they'll select patients who improved by 10% or sometimes 20%. And we feel that that's not quite justified by these reliable change measures. So to give you an example, if somebody was able to do the pre-test at in 20 seconds, in the post-test, they need to improve to at least 14 seconds. And it's proportionate to how impaired you are at baseline. So it's not a fixed number of seconds, right? So similarly, if somebody was able to do the pre-test in 50 seconds, in the post-test, they should be able to do it in like 36, 35 seconds. So it's proportionate to their baseline improvement. So if somebody doesn't get better with DLP, that's when we consider doing a CSF drainage trial, provided their neurodegeneration biomarkers come back negative. So when we do the LP, we now routinely test for CSF amyloid ratio 42/40, beta 181, and NFL. If those are negative, we send them for the extended drainage trial, where the goal is to drain 300 to 600 cc's. And in contrast to the large limb LP, this has a much higher negative predictive value. It means if you don't improve even after draining 300 to 600, which essentially is a physiologic mimic of a shunt, then you're not likely to improve. And conversely, you have to factor in the risk of meningitis. When we first started this program, the risk of meningitis was around 2%, and now it's less than 0.5. And that's because we started using DuraPrep, antibiotic prophylaxis before the procedure. We started screening for UTIs, as it's common, you can imagine, in this population with incontinence. If you have a UTI, we treat it before we bring them in. And we started doing the procedures in an IR suite with sterile precautions, as opposed to the bedside. So what are our current criteria for shunting? So, we think of cognition as multiple domains, but generally we are not used to think of gait as having multiple domains, but there are. Gait is not just, how fast you walk, but speed is definitely important, but even more important is balance, because that correlates with falls better. And we often miss endurance. A lot of our patients with NPH say they can only walk a block or so, and then they cannot do it anymore. So we do multiple tests for these domains. We also take a video, and we have it blinded assessment in case conference if there's any disagreement amongst these measures. And we've been doing this for a while. One of our earlier studies showed that as long as you select patients carefully for shunting, just going back to this, so we need patients to improve in at least 2 of these 3 domains by a significant amount for us to feel confident that a shunt will help them. So once you use a more selective criteria for selecting these patients, then outcomes are much better than what are averagely reported. Nearly 80 to 90% of our patients had sustained improvement at 7 years after shunt surgery. Coming to this controversy, is the NPH phenotype just a pre-degenerative phenotype of all these disorders? And there was a fairly controversial editorial in the Annals that called for a moratorium on shunt surgery. He observed that not many of his patients had objective long-term improvement. More than half of those who improved initially failed to show improvement later on, and that we should stop shunting outside of randomized placebo-controlled trials. And the paper that accompanied this editorial was a paper, I think, out of Case Western, where they have a series of patients that were referred to them for shunt surgery. Of the 142 patients referred to them, they shunted around 31 cases. And of those 31 cases that they followed for 2 to 3 years, only 10 of them had improvement. And when they looked at the patients who did not have improvement, there was a mixture of different disorders, DLB with 3, 2 Alzheimer's, 2 PSP, 1 vascular dementia. Similarly, in the small pilot trial, they found that of the 13 patients shunted, only 4 had sustained improvement at 3 years. Another article from the European group, about 50% have alternative cause of dementia. Another small study out of Penn, where they looked at 37 patients that were selected just based on clinical presentation and imaging. So they did not do any further diagnostic testing like a large limb lumbar puncture or drainage trial. And they found high prevalence of amyloid plaques, and nearly 1 in 4 of their patients had AD pathology, so both tau and amyloid in their frontal cortex, which would be equivalent to a BRCA of 5 or 6 for tau, so fairly advanced Alzheimer's disease. The largest group of biopsies was done by Ville Leonen in Finland, where they again looked at 468 patients who were referred to them for NPH. In Finland, they have this great protocol where every time they put a shunt in, they take a small cortical biopsy and send it for histopathology and immunohistochemistry. Around 25% had AD pathology, so fairly large number. So we decided to see if the same held true in our patient population. And if we selected patients more rigorously, was this proportion of comorbid neurodegenerative diseases the same or lower? So this was based on different gait tests we used to administer back then, different scales, which we changed over time, but we still needed improvement in 4 of those 5 tests to select patients. So we did, classic silver and immunohistochemistry for both amyloid and tau. We also stained for alpha-synuclein. And in our cohort of 88 patients, so only 6 of them had, advanced AD pathology, and the amyloid plaques around 1 in 4 had amyloid plaques. But you have to remember that this is the same prevalence, 1 in 4 of people who are in their mid-70s, essentially a population, right? If you just go out into the community and evaluate mid-70s people, about 1 in 4 will them have amyloid plaques. But only 6 of these 88 had advanced AD pathology, and none of them had Lewy bodies or alpha-synuclein by immunohistochemistry. So we looked at, what predicted who had tangles, and clearly people who are older had more tangles. But very importantly, if gait came before cognition, then there were hardly any people with tangles. Whereas if cognition was affected at the same time or before gait, then they were more likely to have AD pathology. So not surprising there. But as you can imagine, doing biopsies is still fairly invasive. Even though you take a small cortical biopsy at the time of shunt surgery, some of these people will have a tiny cortical hemorrhage at that area or develop immediate post-operative seizures. So we decided if just measuring these biomarkers in CSF, can they help exclude neurodegenerative pathology? Don't have much time, but I'm going to try and do this quickly. So we looked at around 420 patients who were referred to NPH. About 402 had INPH. Around 1/3 of them improved after the LP and got a shunt. 2/3 of them did not improve, so they likely had some other disease. Of the 121 people that we followed for a median of 2 years, 31 did not have improvement, whereas 90 had a sustained improvement. So we wanted to first look at, can CSF biomarkers predict who improves after the LP? Can CSF biomarkers predict these 121 people? And a second outcome was, can CSF biomarkers predict who have a sustained improvement, meaning like an average of 2 years after shunt surgery? Can CSF biomarkers predict that? So we looked at, so TT response is TAP test, which is often an acronym that's well accepted in this literature for a large volume LP. So we looked at people who had the TAP test and what their differences were, and people who were selected for shunt surgery from this group and who had improvement versus no improvement. In the short term, as you can see, people who had a larger Evans index or evidence of transependymal CSF flow were more likely to improve after the TAP test. And as you can see, when we followed these patients for over 2 years, the people who improved, their mean tug improved from 36 seconds to 18 seconds. So nearly a 50% reduction in the time it took them. So their speed improved by almost 50%. Whereas there was a group of around 1 in 5 people whose tug actually got worse over those 2 years. So they likely had something else going on. And these were the biomarkers we looked at, the classic AD biomarkers. NFL, while not specific, it is a fairly sensitive marker for many neurodegenerative disorders. And LRG1, which is leucine-rich glycoprotein, which has been identified as a biomarker in multiple meta-analysis of patients with NPH. So we looked at all of them. And maybe I'll just come to the most important figures. So none of these biomarkers help predict improvement just after the LP. The MRI helped, the Evans index helped a little bit, age helped a little bit, but none of the MRI biomarkers were able to predict who improves after the LP, like an immediate improvement after the LP. But then when we looked at long-term improvement, which group of biomarkers can predict long-term improvement, like 2-year outcomes, a combination of p-tau and NFL, gave us a good prediction of fairly good AUC of around 0.82. So nearly 85% of patients selected for shunt surgery had absolutely normal CSF p-tau and normal CSF NFL levels. So they don't have some comorbid neurodegenerative condition going on. So based on both our autopsy, our pathology study, the biopsy study, as well as the more recent CSF biomarkers, we can confidently say that NPH is not just a pre-degenerative phase of neurodegenerative disorders. And we are not shunting patients who are destined to develop this at a higher rate than the background age-related incidence. Why have there been no double-blind randomized controlled trials? So to essentially do that, you need a shunt that has a complete offsetting. And until fairly recently, like in the last 10 years, I would say, there were no such shunts. Shunts could be either more open, less drainage, or more drainage, but you couldn't completely switch them off. There was a lot of reluctance from patients, as well as IRBs that about putting shunts in and turning the shunts off for like 3 to 4 months. Unlike DBS, where you can switch on and off fairly rapidly to look at changes, the effect of shunts is not immediate. It can take weeks, sometimes months, to really see that full benefit. People have tried. People in both the UK and Japan have tried doing pilot studies. Often they were not able to meet their numbers required because of difficulty recruitment. But in whatever small pilot studies they did see an improvement after true shunting, meaning they randomized some people to an offsetting, some people to a open setting, and did see a trend towards improvement. So we did a pilot study at Hopkins like about 3 years ago, and we randomized people to an open shunt setting group, just 18 people, just to collect some pilot data, who had a setting of 4 on the Codman-Surtas valve, and a setting of 8, which is a virtual off on the Codman-Surtas valve. And the open shunted group, was followed for 12 months. The placebo group, or the closed shunt group, had the shunt off for the first 4 months, and then they were opened up. So as you can see, the blue bars are those who were closed, meaning their shunt was closed for the first 4 months. And as you can see, their gait velocity over the first 4 months did not change at all. Whereas in the people who had an open shunt, their gait velocity improved over the first 4 months and improved a little further more at 8 months and so on. Whereas, as you can clearly see, when the closed shunt group had their shunt opened up at 4 months, their velocity clearly improved at 8 and subsequently at 12 months. So because of the small numbers, we didn't quite reach the threshold for significance, but it gave us enough confidence to go ahead and do a much larger trial. So we were just funded along with other sites to do this 20-center study across the US, Canada, and Sweden, where we are screening around 400 people. 100 are going to be randomized, 50 to a virtual off for the 3 months, and 50 open. The study is in the second year. We've recruited around 20 patients so far. And the primary outcome is the 10-meter walk time in this trial. And there are secondary balance outcomes and cognition outcomes and bladder outcomes. And interestingly, because we are screening a large number, we are going to get CSF from all these 300 to 400 patients. So we can further characterize this population in terms of their biomarkers and their eventual response to shunt surgery. I don't have time to go through a video, but but this is a typical gait of a patient. So you can see the feet are widely placed.
Abhay, feel free to show the video. We're fine.
Oh, so can you see the video? It's playing on my screen.
Yes, we can see it, and
Okay.
show the whole thing.
Okay. So as you can notice, he has great difficulty making that turn. This is a classic magnetic apraxic gait. But it does take him a long time, and he almost falls down. Sorry, I can't make it stop now. And that's him walking immediately after the LP. So clearly not normal, but it does take him just 6 steps to make that 180-degree turn as opposed to 30 for that previous turn. So he almost falls down on the left. I thought I had to write a hero report or something. So to conclude, NPH is rare, but it exists. Patient selection is critical for good outcomes. With stricter criteria, we definitely have better outcomes. And long-term studies do need to account for comorbidity as this patient population is susceptible. You do have to worry about shunt malfunction. Shunts are still not perfect devices. 10% of shunts fail every year. So over 5 years, nearly half the shunts malfunction and need to be replaced. And just doing a shunt series or an X-ray is not going to tell you if CSF is actually flowing through the shunt. You need to do functional shunt studies. You have to inject, technetium in the shunt bulb and see if it flows down into the abdomen as it's supposed to. So a nuclear medicine shunt patency study is often needed to identify if the proximal or the distal catheter is blocked. And importantly, we should stop calling NPH a reversible dementia, but it is a reversible gait disorder. And just to highlight, when I got into this clinic, I was a little skeptical and hesitant to take over the CSF disorders clinic because my primary focus was Alzheimer's disease and biomarkers. But over time, I eventually realized the importance of doing this, and I wear a different hat. I'm the biomarker co-leader for our ADRC. But looking at these patients and getting deep phenotype and cognition data and CSF, and eventually we started collecting blood and DNA from these patients, allowed us to build a large biorepository. So now we have over 3,000 patients where we have CSF from patients who were referred to us for NPH, but incidentally, the patients who don't get shunted have one of these neurodegenerative conditions. So we've been able to collect a big number of samples for other disorders too, and that has helped us do pilot studies, that has helped us develop preliminary data, which have been used for applying for grants. So the PENS NIH study was based on some of this work that we did, for ongoing studies at the ADRC, including launching a study of aging called the BioCard that we are doing. We've used this repository to identify novel markers and to justify why doing it in more longitudinal cohorts is valuable. So this program has had a dual benefit in both in terms of clinic and research. The patients are already there. Why not collect CSF blood and have it useful for many other projects? So with that, I would like to thank. So this is the first group that started doing this in a comprehensive manner. So Rich was instrumental in getting me in this program. Daniel Rigamonti was a neurosurgeon back then. David Solomon was a dear colleague of mine who's now passed away, who helped a lot with setting up this program. And our current team is Mark Luciano, who's a neurosurgeon, Sevil Yasser, who's a geriatrician, Aruna Rao, who does the ELDs, a physician assistants, and more importantly, the physical therapy team that's so critical to get objective measures of gait from these patients. Thank you. We don't have time for this, but I'll take questions.
Thank you so much, Abhay. So questions from the audience here? All right, I'll ask you a question, Abhay.
Yeah.
So how can you use neurofilament light as a biomarker to inform a clinical decision if it's not FDA approved as a test?
Good question. We do caution our patients that this is based just on a single center analysis. But yeah, we do have to caution patients with that. The other thing is if somebody does improve remarkably in their gait, right? We don't necessarily refuse shunt surgery for them, but we do caution them that these high biomarker levels suggest that you have something else going on. And while you may benefit in terms of your gait, we cannot assure long-term improvement, like 2-year, 3-year outcomes. We just don't know. And some people,
That's for the people in the audience. A lot of research trials are now telling results to the patients, but the FDA says you can't use a research result to inform a clinical decision. So you just say it didn't inform your decision, even though it did.
no, I think the NIH is actually, there was actually a symposium about this, about releasing research results to patients.
They said, fine, do
Yeah,
it.
yeah,
But you're not supposed to make a clinical decision based on it.
correct.
That's I was just wondering, yeah, but everyone does.
Yeah.
We'll keep that quiet. Marvin asked, what about cognition long term? But you don't test cognition in the short term, but in the long term, it doesn't get worse.
No, I didn't have that data to present over here in these slides, but we did look at cognition. So in contrast to gait, fewer people improve in their cognition at 2 years. Yeah, it's around 50%, as opposed to like around 80 to 90% for gait, where we do MOCAs at follow-up.
Does ApoE genotype have an impact on outcome, Abhay?
Yeah, we haven't looked at that. And we did cite that as a limitation in our paper, that we did not look at ApoE genotype. We are looking into ApoE proteotyping in CSF, because initially we were not collecting blood for DNA. We just have CSF. So at CSF, we can either proteotype them E4 positive or negative, and we are looking at that right now.
So here's a question. Abhay, do any of your patients ever have evidence of increased intracranial pressure?
So there is this group of patients called as LOVA or SHIMA, late onset ventriculomegaly of adults, or the syndrome of hydrocephalus in middle-aged, in which people in their 40s and 50s, have hydrocephalus from birth that was compensated, but over time they decompensate. And some of these patients have features of high pressure, like an empty sella, borderline high intracranial pressures. And in contrast to NPH people who manifest with gait first, these middle-aged folks do manifest with cognitive symptoms first. So yeah, we do see them.
Any questions in the room? So one important message, that not all enlarged ventricles in adults is NPH, because some people carry congenital hydrocephalus and it's only diagnosed when they're they have a headache or get in a car accident and someone does a CAT scan on them. What do you do in a patient like that? And as you know, Abhay, their ventricles can be gigantic. What's your advice on that patient group?
Yeah, it's easy to identify these patients because they all have a big head circumference relative to their height. So we measure the occipitofrontal circumference in these people, and anyone about 95%, likely has had it since birth. The evaluation for these patients still remains the same. Do they really get significantly better after the LP or the extended lumbar drainage trial? The one caution you have to keep in mind is that it's easy to overshunt these people and they develop subdurals easily. So you have to start at high shunt settings to make sure they don't develop subdurals. The criteria for selecting them for shunt surgery still remains the same.
But what we commonly see, Abhay, is people with clearly have congenital hydrocephalus and then start having cognitive problems, yet don't have biomarkers of a neurodegenerative disease, and their walking's not bad. Is that adequate for a shunt?
So in these rare groups,
I sent you a patient with that exact story.
Yeah, there is no data for this, and this is a small group of patients. We are cautious about recommending shunt surgery for these patients. We often will do detailed neuropsych testing serially to see if in fact they're actually changing over time. And if they have significant deficits that are clearly subcortical, then we do a drainage trial with pre and post detailed cognitive testing instead of just gait testing, but far and few in between. And there, you need to improve in at least 2 of the cognitive domains. And typically, working memory, executive function are affected. Memory is affected, but language is generally spared. Visuospatial construction is generally spared.
So two last, and I'll let you go. Wayne asked about protein, not changed. And then Abhay from Kevin Van Landingham, he wants to ask you about your thoughts on the glymphatic system, NPH, and neurodegeneration. You can
Yeah.
do 30 seconds.
Yeah, I mean, the protein, we don't find the protein to be higher in NPH compared to age-adjusted normals. Often with aging, the protein level can increase a bit. Now, even if you have significant spine disease, for some reason that causes a slight elevation in your protein. Obviously, if you're diabetic, your protein is elevated, but we don't see higher protein in people with NPH compared to their age-matched group.
And then what about, do you think about the lymphatic system at all?
Yeah, I mean, that's a separate lecture, I think, but it's so controversial. I think, there's a lot of controversy in the field about the venous outflow of the glymphatic system and what the exact outflow is. The inflow seems to be less controversial around the periarterial spaces, potential spaces, but where does it get out on the venous side is quite not clear. There have been people who have had difficulty replicating the data from 2 labs that have been advocating for the glymphatic system. So I think that remains to be seen.
Yeah, the first time I read that paper, that's what I said. Well, let's wait for the replication of that. It all seemed too much like room temperature superconductivity and things of that sort. Anyway, Abhay, can you do a glymphatic talk?
Actually I can. I mean, I'm very,
awesome.
Yeah.
I still can't quite figure it out. It's just 2-3-dimensional for me.
Yeah.
But anyway, Abhay, you look great. We miss you down here, and hopefully we'll get you down here soon.
Great. Thanks, Rich, for this opportunity. Yeah. Bye, everyone.
Maria, thank you so. I mean, your laptop saved us. Your laptop saved us from disaster. I mean, God, we would have been
I
dead.
didn't expect to use it, but I was like, I'll just bring it just in case.
And I didn't bring mine.